Well, good evening. All right, so let's get started. So today we're going to talk about urinary incontinence and pelvic organ prolapse. And a few of you have heard parts of my kind of spiel on this topic, but today we're kind of going to cover the full breadth and depth of these two topics. So just moving on. So we have a disclaimer that talks about this evening is sponsored by Coloplast, but really we're going to talk about kind of the evidence regarding urinary incontinence and pelvic organ prolapse. So our agenda today, first we're going to talk about urinary incontinence. What is urinary incontinence? How does the urinary system work? Causes and types of urinary incontinence. How do we diagnose it? And really how do we treat it? Both non-surgical and surgical options. The second half of the talk today will be on pelvic organ prolapse. It'll include the definition, the symptoms, the different types, as well as how is it diagnosed and how is it treated, both non-surgical and surgical options. And then finally, we're going to conclude with any questions, kind of a question and answer period, where you can really ask me anything that you've wanted to ask, a gynecologist, specifically a urogynecologist, about these two topics. So moving on to our first kind of important question is, what is urinary incontinence? So urinary incontinence is involuntary loss of urine from the body. And common symptoms can include frequent or infrequent urination, and they can range in quantity from a few drops to total loss of your bladder control. And these symptoms can be triggered by certain activities. So very common triggers are running water, also arriving home. If you pull into your garage, a lot of people have to kind of run into their house because they have a common trigger. And some people have other triggers during their morning commute, like riding a train or things like that. The most important thing about urinary incontinence is to know that it can be treated, okay, and that it's not a normal part of aging. So now facts about urinary incontinence. The first thing that I want you guys to know is it's very, very common. So a lot of people think that it's just them, and it's not. It's 1 in 4 women over the age of 18. So not only is it not a condition of the elderly, but it's very common amongst women in general. And it's just one of those things that we don't speak about. And so approximately 18 million women suffer from urinary incontinence. It's 2 times more common in women than men. 10% of adult women report weekly leakage, but it can be much more frequent than that. And 25 to 45% of adult women report occasional leakage. And 80% of those affected by urinary incontinence can be cured or improved. And that's the big thing that I want to bring home is that this condition isn't life-threatening. It's not something like cancer, God forbid, but it's bothersome. It can impact your life, and it can lead to you kind of adjusting your daily activities, not visiting a friend, not going out to lunch with friends, not going to things like graduations, especially this time of year. And so it's important to know that we can treat these symptoms and we can manage them, and that there are options out there for women. So moving on, this kind of talks about common misconceptions. So I hear these phrases often, nothing can be done, as in it's just part of aging. Urinary incontinence is a normal part of aging. Drinking less fluid will improve urinary incontinence. I have a lot of women where I actually have to tell them that they're dehydrating themselves and they need to drink more for normal bladder function. Some people think that pads are the only option for them, and that surgical treatments require large incisions, prolonged recovery, and they envision that it's a lot more difficult than it really can be. Now the urinary system, so let's back up and kind of explain the anatomy of the system. So you have 2 kidneys. They're what create urine, and they filter waste from the body. Next, you have 2 ureters. Those are the tubes that drain the kidneys, and they then filter down into the bladder, which is just a reservoir for urine. It relaxes to fill with urine and squeezes to empty. The tube that drains the bladder is called the urethra. And for women, there's actually muscles along the urethra that aid in control of bladder function. And those are all important steps in the pathway, and when they're functioning well, all is great, and when they're not, there's different ways that we can intervene to improve your overall bladder function and bladder health. So now, how does the urinary system work now that we know the structure? So like I said, the bladder fills from the kidneys. It's a muscle that relaxes to fill. Think of it as almost a balloon that expands. Once the bladder is full, there's actually nerves that get activated. There's stretch receptors that can tell the bladder when it's stretching and getting full. Then the bladder is supposed to contract. The urethra, or the tube at the end, is supposed to open to allow you to empty. And so you need this coordination of function. And so again, you need the bladder or the dome to contract, and then you need the tube to relax to allow urine to empty. And if it's not coordinated, then you can have different disorders and problems there too. Now that we know what normal function is, then we talk about what happens when things are functioning abnormally. And so now urinary incontinence can occur with everyday common functions like running, laughing, jumping, sneezing, the dreaded jumping jacks at the gym or jumping on a treadmill I hear often. And what happens there is that the muscles that are supposed to keep that urethra closed aren't as strong. So they've weakened with age, with childbirth, with just gravity, and they're not able to withstand that pressure. So a sudden cough and the person can leak. Okay. Also what can happen is that bladder muscle can spasm where it suddenly contracts and then you can leak as well. Some patients have what's called dry overactive bladder, where the muscle will spasm so they can feel it, but they don't actually leak. They just get that sudden sense of urgency that they have to go to the bathroom now. So now risk factors, and so I hit a couple of them. One being childbirth. So a vaginal delivery doubles the odds of urinary incontinence versus a cesarean section. And for each subsequent vaginal delivery, it puts you at risk. So, we can all blame our children for that risk factor. Like many things in life, BMI is also a risk factor because we're talking a lot about pressure and pressure on your pelvic structures, on your pelvic muscles. And the larger your size, it increases pressure. And so there was actually a study that said that if you decrease your weight by 10%, that it can actually improve your chance of urinary incontinence by 50%. So again, there are small changes that we can do that can really help our bladder function. Other known risk factors are pelvic surgery. So many women have a hysterectomy. It's the second most common surgery performed in the United States, and it definitely puts you at risk for both prolapse as well as urinary incontinence. Moving on, age, right? Everything becomes more common as we age, but that does not mean that you have to live with the symptoms. And so age, like we said, gradually increases your risk for urinary incontinence. And then when you think about all these different risk factors, one individual can have many different risk factors. They can have an elevated BMI, they can have a family history, they've had children, they've had pelvic surgery. As you get older, you kind of almost accrue these different risk factors that then make urinary incontinence much more probable for you and a higher prevalence. So other risk factors, smoking. There's different things that can irritate your bladder and lead your bladder to not function as well. Tobacco is an irritant, so smoking is definitely. Comorbidities such as diabetes. When your blood sugar is not well controlled, it's a natural physiologic response for you to produce more urine to help kind of offset the sugar. And so it's very important that you control your diabetes because that will help your bladder function. Things like urinary tract infections lead the bladder muscle to be much more irritable and irritated, and so you can have a lot more urinary urgency. And some women know they have a UTI because they're going to the bathroom more often. They have that sudden urge to go, and sometimes they're leaking more often. Other things that kind of help reveal urinary incontinence are things like high impact exercise. I have a few women who've just started CrossFit, and so they're kind of putting their body under stress that's foreign to it and doing things that they've never had to do before, and so then now they're leaking with those activities. And there's certain medications that also put you at risk for leaking. Now, other than smoking, one of the more severe bladder irritants or very common bladder irritants is caffeine. And so that can be both in the form of coffee as well as tea. Tea is a kind of a double hit because it's acidic as well, so even herbal tea can act as a bladder irritant. One that's not listed, which is becoming more and more important, is carbonation. So that seltzer water that a lot of us drink and love can also irritate your bladder. So kind of the rule of thumb is if you open the bottle and it hisses, try to avoid it, okay? Because it can irritate your bladder. And so now moving on to different types of urinary incontinence. And so these talk about it as its little silos, but most patients have a mixture of different aspects. So the first one on the left is called stress incontinence. And so that's leaking with activity. Cough, laugh, sneeze. Some people just stand up and leak. Others roll over in bed at night and leak. That's still stress incontinence. That's a mechanical issue, meaning that the muscles aren't able to stabilize the urinary system, okay? And so that's usually treated with either surgery or pelvic floor exercises, things like that work on structure. Moving kind of to the left of the screen, urge or urgency incontinence is that sudden loss of urine, okay? What urge is a sudden sensation of you having to go to the bathroom that you can't ignore, okay? And so you'll see women, you know, run to the restroom or pull over on the side of the road. That's what an urge is. Mixed incontinence is a mixture of the different types of incontinence. So some women have both stress incontinence and urge incontinence. Kind of the natural progression of urinary symptoms is that it usually starts with stress, frequently after childbirth, where a woman will start leaking a little bit with cough, laugh, sneeze. They get a cold and they realize that they're leaking. Then they start going to the bathroom more often. They start emptying their bladder because they think that if their bladder is empty, they'll leak less when they cough. And by doing that, they start then developing a little bit of that urgency leaking, meaning that now they've trained their bladder to not hold much urine and they're going to the bathroom often during the day, and some women get up at night to go to the bathroom. And then the last category on the left is abbreviated OAB, and that's overactive bladder syndrome. And so that's a combination of that sudden urge to go to the bathroom, going to the bathroom often during the day, and even getting up at night to go. And that includes some people leak and some people don't. Okay. So now that we know what is urinary incontinence, we know the types of urinary incontinence, we've also reviewed the normal anatomical structures. Now, how is it diagnosed? And so when you come and see me, the first thing I do is take a history. And so I want to hear about, you know, how is your bladder treating you? You know, I say, tell me about your bladder. How often are you going to the bathroom? What are you having to do? What changes in your life have you made because of your bladder function? And commonly I'll have women tell me, you know, I'll go out to eat and I know where every bathroom is. Or I had a patient tell me that she had an app that wherever she went, it would tell her where every bathroom was in that location. So that was almost diagnostic based on that. That needing that app showed me that she's going to the bathroom often. Kind of an objective way to diagnose overactive bladder is to use a voiding diary, which you each have a copy of. And with a voiding diary, what you do, I only have you do it for one day. I have you do it for one 24-hour period, so to capture both day and night. And I have you write down every time you go to the bathroom. I even have you measure your output to see, is your bladder full when you have to go, or are you responding to these abnormal signals from your bladder, okay? I also have you track, what are you drinking? So I know how much fluid you're putting in and how much fluid you're putting out. So then I can make some behavioral changes based on the amount of fluid you're drinking, the types of fluid you're drinking, and even when you're consuming these fluids. There's some women that drink a lot in the evenings and then naturally get up at night. And so we can make some shifts in the timing and types of fluids. And I learned that based on the voiding diary or the bladder diary. And again, like I said, I have you usually do it for 24 hours. Sometimes I extend it out to 3 days or even 7 days if I need a little more information. When it comes to other tests, I'll have you give a urine sample. I'll do a urinalysis to make sure that there's no infection because a UTI is a possibility. I also will do what's called urodynamic testing, which is a way for me to test your bladder function. Sometimes I tend to do that for people who have that mixed picture because I want to know what's the predominant problem. Is it the leaking with activity, cough, laugh, sneeze, or is it overactive bladder, going to the bathroom often, getting up at night? And this test helps me see what's worse so that I can guide treatment based on that. I think of a urodynamic test almost like a stress test for your heart, where it's the best way for me to test how your bladder's functioning. If my patients don't respond to the initial treatments, then I do what's called a cystoscopy, where I can perform it in the office, where I look in the bladder and make sure that there's nothing structurally wrong with the bladder. You know, there's no masses, there's no stones, there's nothing like that causing these symptoms. So now we're going to move on to different treatment options for urinary incontinence. So like I said, there's both non-surgical and surgical. I always start with non-surgical because I want to start with the least invasive options, the simplest options, and then we move in a stepwise fashion as the symptoms dictate. So on the left of the screen, it talks about non-surgical, so things like pads, which usually patients come in already using, medications. There's different medications on the market. One class is called anticholinergic medications. What the medications do is they work on the bladder muscle and they make the bladder muscle relax. Because again, what you want your bladder to do is just expand like a balloon. You want it to fill with urine, and then when it's full and you're in the bathroom, undressed, ready to go, to squeeze and then empty. What you don't want it to do is keep having those spasms, okay, when it's not full. And so what anticholinergic medications do is they allow that bladder to relax. The problem with those medications is that they're not specific to the bladder, They work on other parts of the body, and so they lead to some side effects. And so common side effects on anticholinergics are dry mouth, okay, and sometimes even constipation. And we know that one of the best ways to improve your bladder function is to actually improve your bowel function. So we don't want constipation because that can result in even worse bladder function. We do have medications in other classes that aren't associated with the dry mouth, but in general, those are the medications we use. There's other treatments like bladder Botox. What that does is we actually, through an injection scope, where we put a scope in the bladder and we make several injections in the bladder muscle, we deposit what's called Botox. What Botox does is it paralyzes muscle. And so it works on the actual junctions of the muscle fibers to prevent that spasm, okay? The issue with Botox, though, is that you can overcorrect, meaning that we can almost paralyze the muscle where now it's not functional, okay? Because you want the bladder to squeeze so you can empty completely, but then you don't want it to squeeze too often because then that's overactive bladder. And so it's this kind of Goldilocks state that you need to be in, where it's not too active and not underactive. It's, it's just right for you to empty well. Other surgical treatments, we have what's called sacral neuromodulation, where we can actually implant a pacemaker for the bladder, okay? And what that does is it doesn't work on the bladder muscle, it actually takes a step back in the pathway. So what nerves are, the nerves are almost the wires that control muscle, okay? So the medication, the bladder Botox, that works on the muscle, that works on the actual organ. What sacral neuromodulation does is it works on the nerves. The nerves are what tell the muscle what to do, okay? And we know that in some women, the nerves aren't sending the right signals. And so what sacral neuromodulation does, or what's called interstim, what it does is it works on the nerve to modulate the signals. And so the way that we think it works is that the bladder, again, is overactive. It's sending all this abnormal noise, essentially, to the brain. Your brain has learned to listen to the loudest signal, okay? And the loudest signal it thinks is important, and it devotes attention to that. So what sacral neuromodulation does is it actually quiets that signal, because we know that that's not based in reality. We know that it's not because your bladder's full. It's not because you need to attend to that. It's an abnormal signal. So that's what sacral neuromodulation does. But it is an implanted device. And so it does require a couple trips to the operating room. So now we're going to talk about treatment options for stress incontinence, because again, there are two different types of things. So urinary incontinence is a bladder function problem where that bladder muscle is spasming. Stress incontinence is a structural problem, meaning that the muscles aren't strong enough to withstand the pressure, okay? And so because stress incontinence is a structural problem, it tends to be treated with either strengthening the muscles or by actually putting in a graft to help do that. And so now non-surgical options for stress incontinence. The first one is lifestyle changes. Not so much drinking less fluid, I don't really agree with that point, but when I say lifestyle, I talk about decreasing weight. So definitely if you can decrease your weight by that 10%, that decreases that pressure and can improve your overall urinary control, okay? Kegel exercises, those are pelvic floor exercises that strengthen the pelvic muscles. The problem with Kegel exercises is it's easy for a physician to say, do them, strengthen your pelvic floor. It's hard to know how to isolate your vaginal muscles. Those aren't muscles that you typically exercise. And so a lot of times we send you for what's called pelvic floor physical therapy, because they're able to teach you how to isolate those muscles. Pelvic floor physical therapy is actually a type of physical therapy. It's usually done by female physical therapists who've done subspecialty training in issues of the pelvic floor. And so they treat diagnoses like urgency incontinence, prolapse, stress incontinence, as well as bowel dysfunction, things like constipation. The other option is called a pessary, and I think we have one floating around. So this one is a ring with support, which is this mesh here, and a knob. What this knob does is help support the urethra, the tube that drains the bladder, and help support the tissue and the muscles that have weakened, okay? And so it's a plastic device that sits inside the vagina, similar to this picture here, but it's a different shape, and it provides support. Now this pessary can actually be in the vagina for 3 months before it needs to be removed. And commonly, I can teach women how to actually manage it themselves where they can take it out and replace it themselves, okay? And we can pass this around. It's a soft plastic dish. One pessary you can use for 1 year, okay? And let's go back to where we were. Perfect. All right, now moving on to surgical interventions. So now one surgical intervention, and actually the best surgery that's been shown to work the most and to be the most effective for this is called a sling, okay? And there's different types of slings, but the one that's kind of the leading ways to manage stress incontinence is called a mid-urethral sling. And so what it is it's a piece of mesh, okay, which is a graft material. It's a piece of plastic, of polypropylene, and it actually provides a hammock for the urethra. So like I said before, the urethra is that tube that empties the bladder. The muscles around the urethra are supposed to stabilize it so that when you cough, sneeze, jump, that urethra doesn't move, okay? But with age, with childbirth, and just with gravity, those muscles become weak. And so what we do is we implant a sling to help support them, okay? And I have a sample of the sling. And so it's a small piece of mesh, okay? And like I said, mesh is a piece of plastic, okay? That if my finger's the urethra, it goes around like this, scars in place, and provides support. So if you were to suddenly cough or sneeze, it wouldn't allow that urethra to dip because that would activate the sling, okay? And so it would prevent that movement. Now this sling has 2 anchors, one on either side, and these actually anchor into what's called the obturator membrane, which is a strong tissue in the pelvis to keep it in place and prevent it from moving, okay? And the best part about this sling, and we can move on, the best part about this sling, and that's the one on the far right, is that it doesn't pass through muscle, okay? Because passing through muscle can result in pain. But it's held in a very strong tissue, so it's held in place. And so that will pass along. The stitch on the end of it with the loop, that's to help me tension it, to make sure that it lays gently against the urethra, but isn't over tightened. And so in this picture, just to orient you, there's 3 different types of slings, okay? Starting on the far left side, what you're seeing is the bony pelvis, which is kind of the white area. The bladder is the dome here, and the urethra is the tube that drains it, like I said, okay? There's 3 different types of slings on the market in general, and 3 different types of approaches. One that you may have heard of is called retropubic, and so what that is, it's almost a U-shaped piece of mesh, and it goes right behind the bone, okay? This is the oldest sling on the market. It actually is just as effective as the different types, but it has the most research behind it. The downside to this type of sling, though, is because it passes so close to the bladder, it's associated with a higher risk of bladder injury. And over time, a patient can develop what's called urinary urgency. So that going to the bathroom often, getting up at night, okay? Now, the one in the middle is called a transobturator. It's named by the space that it passes through, okay? And so, unlike this one, which is almost kind of V-shaped, this is more of a U-shaped sling, meaning that the path of the mesh is U-shaped. It goes through that obturator area, which is this hole here, but then it also passes through the muscles in the anterior part of your thigh and exits out that way. So it has been associated with some groin pain and groin discomfort. And then moving on to the left, this is called a single incision sling. And the reason why it's a single incision is it's named based on how we place it. So it's also located along that mid-urethral area, okay? And it supports similar to a transobturator, except for it doesn't exit out that anterior part of the thigh, okay? And so it's not associated with that muscle pain because those 2 anchors that I showed you, it anchors into the membrane in this obturator area, okay? And so those are the 3 different types of slings. They all involve that synthetic polypropylene mesh. Okay. So now general risks involved with surgery. So now there's 2 risks involved with every surgery, and that's a risk of bleeding and a risk of infection. So whenever we make an incision or break your skin barrier, those are risk factors, okay? When it comes to infection, we give you antibiotics beforehand to help decrease that risk. Other risks associated with stress incontinence involve if we overtension the sling, There could be a risk that you have difficulty emptying, okay? As we under-tension the sling, you can still leak some with cough, laugh, sneeze. And whenever we do these procedures, we put you to sleep, and so there are some risks related to anesthesia. So now the benefits, it's a short procedure. The procedure lasts anywhere from 20 minutes to 45 minutes, and that includes putting you to sleep, doing the procedure, and waking you back up, okay? It's an outpatient procedure, so you go to either the surgical center or the hospital, have the procedure done. You know, if you come in that morning, you have the surgery, you leave by early afternoon. You do need a ride home because we do put you to sleep, and so you can't drive immediately afterwards. There's a quick recovery time. You can return to work the next day, because really what you have is that small incision, okay? So my restrictions are just based on that incision's there, and it's closed with stitches, and so I don't want you to pop a stitch and open that. And so I say, you know, no swimming for a week because I want that incision to close and I want to decrease the risk of infection. And I say no vaginal intercourse for 2 weeks, just to allow that incision to heal. Now, risk factors, the sling does involve mesh, so there is a risk of mesh exposure or erosion. That's approximately 3%, okay? If that were to happen, usually the physician notices it, meaning that when I do your exam, I can see a little bit of the mesh vaginally. The way that we treat that is I give you vaginal estrogen cream to allow for your vaginal tissue to then heal over that defect, okay? And usually that's the end of it. If it's a larger piece of exposure, then I may remove that part of the mesh, okay? And I can do that in the office. There is risk of infection. That's more of a UTI. The mesh is an inert plastic, and so the mesh doesn't get infected. And with any kind of surgery, there's risk of injury to the structures nearby. So to place the mesh, we place it near that midurethral area or the anterior vaginal wall, so the top wall of the vagina. And so there is risk of injury to the bladder because the bladder sits above that, okay? And after we place the sling, I actually take a look in the bladder while you're still asleep to make sure that there's no injury, okay? Just as a safety check as part of the procedure. The most common place to have a mesh exposure would be vaginal through the original incision, and so I would see on an exam. So if I do surgery on any of my patients, I see you back 2 weeks after, and then I usually see you 4 weeks after that, and then yearly, just to check to make sure that everything is healing. Because a mesh is a permanent implant, and so it'll be there forever. Okay. Okay? And so
it never has to be replaced?
It doesn't, okay. No. No, it doesn't dissolve. It's a permanent implant. It gets incorporated in your tissue. The reason why we use mesh is because it promotes a scar. Okay. And so it helps to support that area. Let's see where we were. So now, recovery, what to expect. So things that the way that I limit your activity or the restrictions I give you is no excessive lifting. And that's again, just because I don't want you to open that incision, okay? The sling will not move. It is anchored in place, okay? And so that's what we say, no strenuous exercise, no heavy lifting. And that's just to allow for those stitches to dissolve and for that anterior vaginal wall to heal. When it comes to insurance information, these procedures are covered by insurance, okay? And we do check your insurance beforehand before we schedule any surgery because we don't want any surprise bills. And now moving on to prolapse. So now what is prolapse? So it's a disorder in which one or more of the pelvic organs drop from their normal position. The different organs that can move, this can affect the bladder, the uterus, the rectum or the bowels, as well as the vagina, and even the small bowel. And so I'll show you that in picture form because it's a little bit easier to understand in that way. So now when it comes to prolapse, prolapse is even more common than urinary incontinence. So half of all women between ages 50 to 79 say they have symptoms of prolapse. And these are the people who report it. And I would guess that many more women have prolapse and they don't even know, okay, because it has varying degrees. Approximately 300,000 surgeries are performed in the US each year for prolapse. And 1 in 3 women who have prolapse actually have multiple surgeries. And then many people who have prolapse, they also can have stress urinary incontinence as well as other urinary incontinence symptoms. So now this is the pelvic area. So this is a normal, well-supported female pelvis. And so here's the bladder with the urethra that we spoke about. Here's the vagina. The top of the vagina is the uterus where you get pregnant and deliver from, okay? And then the back wall is the bowels. And then here you'll see the pelvic muscles. And so those are called your levator ani, which are just a basket of pelvic muscles that are supposed to support all the pelvic structures in women, okay? But the big thing is the vagina, which is here. So now what goes wrong with prolapse? So like I said, the levator ani is a group of pelvic floor muscles that tend to be a basket to hold everything up, okay? And sometimes, as we get older, with childbirth, with some of the same risk factors as urinary incontinence, these muscles can become weak, can become injured, and can stretch, and they no longer are supporting those structures. And so really, prolapse is when the structure that should be held high and supported start to sag, okay, and come down. So now prolapse symptoms, women can feel heaviness or pressure. These symptoms actually get more severe at the end of the day, okay, when you've been kind of on your feet all day. Some women report vaginal pain. You can have a pulling or aching feeling in your lower abdomen. Some women have pain during intercourse due to prolapse. And you can have difficulty emptying your bladder and bowels due to prolapse. Prolapse causes vaginal childbirth, menopause, being overweight or that elevated BMI. And then things that put increased pressure on the vaginal wall. So like a prolonged cough, constipation, where you're bearing down and pushing and straining to empty your bowels. And if you have any kind of pelvic organ tumors or other kind of masses pushing on those structures. So now there's different types of prolapse, because remember before I mentioned heavy lifting can as well, absolutely. So I see that in women who are movers, some people who actually do a lot of housework, and even women who help shovel snow. There's a lot of lifting, a lot of straining can help weaken those pelvic structures. So now the first type of prolapse is called anterior vaginal wall prolapse, or what's called a cystocele. And this is when the anterior vaginal wall, or that top wall where the bladder sits above it, starts to fall, okay? And so I'm talking specifically about this area here. And so it's where that top part of the vagina starts to come down and sometimes can even come outside of the body. This is one of the most common types of prolapse. And so when people say that my bladder fell, that's what they mean. They had a cystocele. Now a rectocele is the same idea of a cystocele, but it's involving the posterior vaginal wall or the bottom wall, okay, where the rectum sits below it. And so usually this wall can actually bulge up a little bit. And so that's what you see here, where this wall is bulging into the vagina and it can come out as well, okay? And this is common in women who've had a long-standing history of constipation, where women say, ever since I was a little girl, I've been constipated. And the problem with this is that you have constipation, so you've been straining, you've been kind of pushing and bearing down, you then develop this defect, but now you have a pocket where you can trap stool. And so it ends up being this vicious cycle of straining and pushing to empty your bowels that then makes this worse. Now that you have it, now you have to strain and push to empty your bowels. And so without treatment, things just end up getting worse and worse. Now the next type of prolapse, this happens in women who've already had a hysterectomy, where now the top of the vagina isn't well supported anymore, and it can allow the small bowel to come down. And sometimes as a physician, when I look in the vagina, I can actually see the top of the vagina move, because your bowel peristalsis or moves to allow you to empty, okay? And so this is common as well. And this is mostly in women who've already had a hysterectomy. And just like that, that vaginal vault, or the top of the vagina, can come down as well, because it's no longer supported. Because when we do a hysterectomy, which is remove the uterus, we have to cut the top of the support to the vagina. And if we don't then restore that, there's nothing supporting the top of the vagina, and then it can fall, okay? And that's called vaginal vault. Now, the next type of prolapse can happen in women who still have a uterus. The uterus is the heaviest structure in the vagina. And so we can kind of be the leading edge of prolapse and can start coming down, okay? And when the uterus starts coming down, it actually can bring the other vaginal walls with it. And so it's as if it's a sock that's turned inside out, okay? And so now that we know what prolapse is, we know the different types of prolapse, we also know the symptoms, now you have to make sure you bring it to your doctor's attention. Because commonly I'll see women for other things and mention, you have prolapse, did you know? or their primary care doctor will mention it. And so, make sure that you bring it up to your doctor. There's common tests that we do. Like I said, we can do a cystoscopy that looks in the bladder to make sure the bladder is intact. Before I do surgery on anyone for prolapse, I also will test their bladder and do the urodynamic testing too, just to make sure the bladder is functioning properly. And so now different treatment options for prolapse. So there's both surgical and non-surgical. So non-surgical treatment options, there's pessaries, which they come in different shapes and sizes, like the one that we have here. There's different exercises to strengthen those pelvic muscles. And there's also pelvic or physical therapy as well. When it comes to surgical options, there's two different types of surgeries that we do. They're either called reconstructive surgeries, and that's where we rebuild the vagina, or they're obliterative surgeries. Now, obliterative surgeries are the type of surgeries I do in women who aren't sexually active, okay? And that's where I tuck the prolapse into the vagina and actually reduce the size of the vagina. For women who are still sexually active or want to maintain a functional vagina, then we do reconstructive procedures. And there's different types of procedures we do based on the location of the prolapse, okay? Now, on the left side, it shows that if it's just the top or bottom wall that are prolapsing, so either that cystocele or the rectocele, then I do a repair of the top and bottom wall. And that's called an anterior repair and a posterior repair, okay? Which is just a vaginal surgery that we do. It's a same-day procedure. Like I said before, you go into the operating room. We do what's called a nip and a tuck of the top and bottom wall, and then you go home the same day, okay? I don't use mesh for these procedures. Some physicians do. Like I said, there's different surgeries that we can do without any kind of implant, whether that's synthetic or something permanent or something biologic. There are different types of grafts that we use. So like I said, I don't use grafts vaginally, but I do use them abdominally. So for women who have uterine prolapse, meaning their uterus is coming down, or they have vaginal vault prolapse, meaning the top of the vagina is coming down, what I do is what's called a sacral colpopexy. And that's a fancy term for supporting that vagina, okay? So what I do is I attach a piece of mesh, and I'll pass that. So it's a Y-shaped piece of mesh, okay? And if this is the vagina, I suture it to the bottom and the top, like this, and it has a tail. And I secure the tail to a anterior ligament on the sacrum. And so what it is a strong piece of tissue to secure it to. So think about it, the vagina, as if it's a sock that's turned inside out. I then grab that edge and write it again, okay? And so I'm restoring and reconstructing the vagina so it's a functional length. And I'm securing it to prevent it from happening again, okay?
Is that through a scope?
Yes, so this is done, I do it laparoscopically and robotically, okay? And so where I make small incisions in the belly and do the surgery through long sticks, okay? This is also a day surgery. It's just longer than doing the anterior and posterior repair. And this is one of our most durable surgeries, meaning the chance of the prolapse coming back is the lowest, okay? Because like I pointed out in earlier slides, many women undergo multiple different surgeries to correct this problem throughout their life, okay? And some women start with just having an anterior repair, and then that prolapse can recur, or then they can develop different types of prolapse, like the uterus can now start coming down, and then we move to this surgery, okay? Because it's associated with one of the lowest risks of recurrence. The reason why the risk of recurrence is so low is because I use the mesh, because I use that graft material. Because thinking about it, if I just use your material, your tissue to support things, it's stretched out once, right? It's already failed one time. And so expecting it not to fail again isn't always the wisest decision. And so that's why mesh was developed, because it promotes a scar and helps support the tissue, okay? And I'm gonna pass this one around, and it's made out of the same material as the sling, that's polypropylene. Now, risks for using a graft is that there's risk of any surgery, bleeding and infection, okay? There's risk of injury to the structures nearby because, again, we're operating on the vagina, so the bladder sits above it, the bowels sit below it, so there's risk of injury to there. And depending on how you do the surgery, there can be risk for painful intercourse if things are overcorrected. So now when it comes to the recovery, so the majority of my patients go home the same day unless there's a medical reason to keep you overnight, okay? And so you wake up, you're in the recovery room. As long as you're able to empty your bladder well, you're not too nauseous and not too sleepy, then you go home the same day. I'll call you the following day to make sure you're doing well. And then I see you in the office 2 weeks after just to check and make sure you're healing well, okay? For prolapse surgery, I do have stricter kind of post-op restrictions, so no heavy lifting for 6 weeks. And the reason why is because I need you to form a scar. That forming a scar is critical to any of the repairs that we do, and I want everything to scar nice and well and supported and not down and out again, okay? And so because there's no strenuous lifting, there's no strenuous exercise, and so I tell you not to go to the gym for 6 weeks, okay? But you can do your everyday life activities. So if you need to go upstairs because you know your bedroom's upstairs, that's fine. You can go for walks. You can drive your car as long as you're not requiring the stronger pain medicine. Okay, you can still do all those things, but you can't run a marathon. You can't do things like that. Okay, because you need to heal post surgery. Like any surgery we do, we make sure that we have insurance approval, okay? And we help to minimize the out-of-pocket cost for you. And then if you guys have any more questions about your pelvic health, that I can't answer tonight, there is a website called pelvichealthid.com that can provide more information, okay, in addition to what's in your pamphlets. Now we're at kind of the question and answer part. So feel free to ask me any questions you have, or if I need to slow down to explain anything again.
Can you discuss the medicines a little bit?
Sure. So for urgency incontinence, okay. So like I said, there's 2 different classes. Yeah, so for overactive bladder. So there's the anticholinergics, and within that class, kind of the oldest medicine, it's called oxybutynin. It's been around for decades. It's very effective, but it also has a high risk of side effects. So dry mouth, constipation. It can also have cognitive side effects. So it can impact your memory and your ability to focus. And so I don't like using that in women who already have some of those concerns, or in some of my elderly women, because I don't want to impact their cognition. Their clarity of thought is important to do that. There is another medicine on the market called maribegron or Marabitric, and it works in a different way. And so it's not associated with some of those cognitive effects. It's also not associated with constipation. Part of the risk factors, though, is it can elevate your blood pressure, and it can cause some drowsiness. And so we monitor you for that.
And how does that one work?
So that works on the muscle. It just works on a different part of the pathway. So anticholinergics work on the parasympathetic part of your nerves, okay? Because it's it works on the ACH pathway. Maribegron works on the sympathetic part, so just another part of your nervous system, and it works in that way, and it works on the receptors in a slightly different way, so it's not associated with the same side effects.
A couple more questions.
Yeah,
the dose ranges?
So the dose ranges, it depends on the medicine. So depending on what you're using, it can be as little as 2 milligrams or as high as 50. So it depends on the medicine. Yeah. Now the dose frequency also changes. There's some medicines that you take once a day, some you take twice a day. But yeah, so it depends. When it comes to anticholinergics, there's a lot of different medicines that are different brands. And so the dosage and the frequencies vary based on how they act.
Okay.
No problem. Any other questions?
Is it progressive in terms of, does it sort of get worse with time? Does it stay the same over time?
You mean overactive bladder? So it tends to get worse over time if it's not treated. And it can change as well, because a lot of times what happens, kind of the natural progression of overactive bladder, is a woman will come in and see me saying, I'm getting up at night, I have this urge, or I'm starting to have accidents, doctor, help. And so then we do the voiding diary. We start having you avoid those bladder irritants. You really have a good buy-in. You start getting better. We may even try a medicine. And then you go on your way. You're doing well. But with behavioral change, you have to do it forever. And a lot of times what happens is you start slipping back into bad habits. And so now we're drinking a little more coffee than we thought. Or even alcohol is a strong bladder irritant. And so now, we may be having our glass of wine at night again. And so then the symptoms can get worse and they can come back again. Because no matter what medicine we use, if you go back to drinking, your 20-ounce Dunkin' Donuts a day, it's going to overpower it. And so you're still going to have problems and leak and have issues there.
How swimming affect in a pool, in ocean, swimming?
How does it impact what?
Is not making things worse.
So swimming shouldn't make things worse. I limit swimming post-surgery because I want to decrease your chance of infection. So if you have a fresh incision and then you submerge it in water, a bath, a swimming pool, the ocean, then it increases your chance of infection. But if you have overactive bladder and you swim, it shouldn't necessarily be a trigger. Sometimes cold, like cold air, cold water can trigger a bladder spasm, so it can make it worse. That would be the only way that I would think that it could impact. But yeah. But in general, swimming is exercise. And it can help you keep your weight down, which can impact and improve your bladder function.
Is there any, stages as to what you start off with first? As far as treatment goes, you start off with medication first. Do you go to Botox next? Do you go to bladder symptoms?
Sure.
Or is it just, it's random, there's no really...
So the way that I do it is I have a care pathway. So what I start with first is actually behavioral modification. So the first thing I want you to do is limit your bladder irritants, because that's a big thing, and to even identify them. So that's the voiding diary, to really see how much do you actually drink a day. Because some women drink 4 or 5 liters of fluid a day. Well, if you drink that much, your body's going to need to empty it. That's more than you need. A normal amount of fluid to consume a day is 42 to 64 ounces. And so for some women, their jaw dropped. It's not as much as they think. And they're super hydrating. So I actually tell them to drink less. Other women, they actually have now started dehydrating themselves. And so I tell them to drink more. That, they actually need to drink more. They need to use their bladder. And so it kind of depends on that. But I definitely start with behavioral modifications. Then I try a medicine. The downside to the medicines is they take about a month to work. And so, so you definitely have to take it every day. And it's hard to be religious to take something every single day and not see a benefit until 4 to 6 weeks after. Okay? So I usually try 2 medicines from different classes, so both the anticholinergic and then the Meribetric, because it's the only med in that class. If they're not better, then I do some of the testing. So then I look in your bladder, so I do what's called a cystoscopy, make sure there's no structural reason why you're not responding to the medicines and the usual treatments. And then I also test your bladder. Is there something else going on? Are we treating, am I sure of what we're treating? Because sometimes certain, there always are those zebras, and so we make sure that it's not one of those. If I've done those testing, then I do move on to the 3rd line treatments. And so there's 3 of them. There's the bladder Botox, there's a sacral neuromodulation, and then there's what's called PTNS, or urgent PC, which is a way that, it wasn't included in this talk, but it activates the nerves as well. And so it works on the nerves. And it's not an implanted device. It's something where you have to come to the office weekly for 12 weeks, and we do it in the office.
Okay. Yeah, what about urethral bulking? Is that done much?
So yes. So when it comes to stress incontinence, then I either do a sling or I bulk the urethra. Bulking is actually more for what's called intrinsic sphincter deficiency. So it's not a muscle issue. It's something that within the urethra there's a deficit, meaning that there's supposed to be a sphincter that closes that tube, and if that's weakened or isn't functioning well, then I bulk.
Do you actually go through all those procedures first before you get to the next, or you double up in the procedures?
So what do you mean by the procedures?
If somebody comes to your office,
Yeah.
If somebody comes to your office who's already had some of these procedures,
Yeah.
and nothing seems to be working, and then where do you start?
So I start where they left off. And so literally what I will show you is my care plan, and we'll check off what you've done before. And there's usually things that have been skipped. And so if they haven't done physical therapy, or if there's something that we haven't done yet, we haven't tried meds in both classes, then I try to pick up on that to see, okay? But if they've done it, they've done it before and it hasn't helped, and now we're down to the 3rd line, then we start there. It's common that by the time they get to me, that sometimes we're at that 3rd line.
How common is it for procedures not to work, and what kind of time frame do you give?
So It's rare for it not to work if we're treating the right diagnosis. So it depends. It depends on what's going on. Sometimes the bulking doesn't work because really they needed a sling. Depending on the type of sling that we've used, sometimes it works, sometimes it doesn't. In my experience, when the treatments don't work, we have to make sure we have the diagnosis right. And we have to make sure that the symptoms that are bothering you, we treated those. Because it's common to have that mixed picture. And so then we have to know, where do we interject? You know, and the tides are turning when it comes to that. So what we used to do is someone would come in saying, you know, I leak with I cough, laugh, sneeze. I also have a sudden urge to go to the bathroom. And we would put a sling in them. And then they'd come back and not be happy because we didn't address that whole urgency side of things. Okay? Now what we're started moving to is address that urgency side of things, because we can always do a sling if we need to. But treating the urgency side can even be more difficult. And so I'd be curious to see what's going on there. But I don't believe anyone's hopeless. We just got to work together to figure it out. And yes, sometimes we do combine things. And sometimes we have to think out of the box so that we can help tailor treatment to address what your concern is. And one of the things I like to do is to see, what is your goal? You know, what is your goal for this? Is it that you can go on a vacation? Is it that you can go and sit through a movie? Go to a lunch with a friend? What is your goal? So that then we can tailor our treatments for you to achieve that goal.
How much is the increase of weight? How much does that really play into it? Or does it have to be a large increase of weight, or could it be just as simple as 20, 30 pounds?
So it can be as simple as 20, 30 pounds. But usually, you know, if we're talking about treatment failure, it's usually more than that. It can be more than that, yeah. Yeah. But losing, you know, working on losing weight, or even maintaining the weight you're at now and not, you know, gaining weight, which is kind of the natural course as we get older, will never hurt you. It will only benefit your bladder function. But I would never tell the patient, you know, you're leaking because of your size alone. There's more to it than just that.
Do you usually get, like, sometimes the OAB or the incontinence leads to some of the prolapse?
No.
No?
No. Mm-mm.
But can you get both?
Yes. So it's very common to have both. Usually the prolapse happens because of you know, childbirth, age, some genetics, which is the way that our tissue is, the amount of collagen, which is just kind of the strength of your tissue, can vary from person to person and can predispose you to prolapse. If you have a cystocele, meaning the top wall of your vagina is moving, you know, it's sagging down, that can bring on some of those overactive bladder symptoms. And by repairing that, sometimes the overactive bladder symptoms can get better. But it's hard to predict that. And so we don't routinely say, you know, let's do an anterior repair to treat your overactive bladder. We don't promise that, because more people will be dissatisfied than satisfied alone with that, if that makes sense. Yeah. But like anything, if the organ is not in the right place, it's hard for it to function normally.
A couple more quick questions.
Yeah.
The website that you had on there was
pelvichealthid.com.
Okay. And do you know of a few physical therapists that are kind of well skilled in this area?
I do. I have a list of them, yeah. So I usually refer people to a physical therapist in their area because it requires weekly visits, and it's usually anywhere from 6 to 12 visits. And so it's a bit of a time commitment. And so I want it to be easy for you, meaning close to where you live or close to where you work, just so that you can go.
Yeah. What exercise and health could normally prolapse?
So Kegel exercises can help. And so that's strengthening your vaginal muscles. Mm-hmm. Other exercises that can also help is strengthening your core muscles. So strengthening your ab muscles and your back muscles can help, because your pelvic muscles actually attach to the bony pelvis. And so it's all kind of continuation there. Okay. Any other questions for me?
Thank you.
Do you, Do you ever get a case where it's because the person is having these problems for so long that now it becomes emotional, distraught, feeling stress? Do you have to look at it that way and treat them for that as well?
I do, yeah. So I would say a large majority of my patients, especially the patients that have tried a lot of things and have failed and they feel hopeless, that absolutely, it would be normal to feel distressed about it. I have many women kind of break down in tears talking about it because it impacts your life. It's a quality of life issue. That's why I do what I do. I'm not curing cancer, right? I'm telling women that you do not have to live with these symptoms. I'm here to help, and we'll work together.
So you won't dismiss them to say, is that just something you just have to deal with and live with?
No, that's not what I say. I can't promise that I can cure you. I can't promise that I can, make you 100% dry or symptom-free, but I can get you better than what you are now, and we'll work together. And sometimes we have to get creative. Sometimes we have to use a combination of things. I need to tailor the treatments to fit you, and I talk about it. That if we have to get creative and we have to tailor things, I let you know what we're doing, and we work together. But sometimes, it's simple things that we haven't thought about. You don't always have to be, use the latest, greatest things. Sometimes it's simple things that can really help. And so we'll see. Okay? Now, if you guys want to make an appointment to see me, fill out the form, okay? And my schedule will give you guys a call tomorrow. And so we can go from there. If you need more information, I definitely come and see me and I can set you up with a pelvic floor physical therapist. We're actually working, we may end up actually bringing one into here as well. That'll be our next step for the Women's Health Center, is to provide pelvic floor physical therapy here because it's so helpful for so many different things.
Now, do you have an office in Northeastern?
I don't. So I only see patients here. I operate if need be elsewhere, but I only see patients here.
Your office in Northeast, that's the one at,
Excuse me.
I've already been there.
Yeah, so that's
The one on Roche Brothers Plaza?
exactly. So yeah, so there definitely is a Greater Boston Urology office in Easton, but I don't go there because we've kind of built out this center for me, and so all of my gadgets are here. Okay, but I do see patients from all the different centers, and all the different physicians will send different patients to me to kind of get my buy-in for different things because I specialize in women.
Oh, excuse me.
Yeah.
What did you say about the physical therapy?
So we are working to bring physical therapy here.
Okay, because you know I need that really bad.
I know, but it's a work in progress, so I can't. It's not going to happen next month, but that is in the back of our mind to help provide all of these services. Because again, I want to provide comprehensive care for women with pelvic floor disorders.
Is this practice affiliated with partners? Or?
So it's not. So I came from Partners. I came from Mass General, but this one's not. I take many different insurances, including Partners, but I'm not affiliated with a Partners hospital at this time. But yeah, and so most women are in network. There's very few insurances I don't take. Sometimes I do need a referral from your primary care physician because I'm a specialist, and that's just the way that modern insurance companies are working these days. So it's hard to call directly in that way. But if you're interested in seeing me, my office is very well versed on how to figure out the insurances and getting the referrals and getting the needed things. There are specialists in that area. So, okay. So on that, I think we're going to conclude. Thank you guys for coming on a Tuesday evening, and I'll hopefully be seeing some of you soon. Okay, thank you.